Thank you very much. This is the result of the surveys that I sent out earlier in the year and that you kindly completed for me. And it was suggested, if you remember, by the previous survey, which looked at causes of burnout, and we had a discussion with emails between the meeting. There was a number of countries who were interested in this project and who contributed both to the questionnaire and to the ideas about it. We finalized the questionnaire in March and then sent out the papers. And it looked for what the current workload of GPs was. What would be a safe workload? It looked at barriers to achieving this, and it also looked at suggested solutions. The first thing we asked was, what is your list size? How many patients are you actually responsible for? And this varied considerably in countries. There were some who had fairly low list sizes, and by and large, they were the ones who found that general practice was sustainable. Others had list sizes that went up to 2,500 and even more. There have been recent data coming in which shows that it may well be more than that, up to 3,000 per doctor. And what would be a safe list size? Most people thought that around 1,000 would be safe, and certainly less than 1,500 per GP. That this would allow people to practice in a manner that was clinically safe for patients and safe for doctors as well. We looked at the number of consultations a day, and although there were 6 countries who felt that, no, they had less than 25 and could manage with that, most countries had considerably more than that. 30, 40, 50 was a common answer. This is too many. If you look at other ways of seeing patients, consultations in hospital outpatient clinics, for instance, they have limits to the number of patients they see in a day. So do solicitors. So do dentists, so do international lawyers. No one sees this many contacts during a day. And in fact, when I looked for information on whether this was safe or not, there are some papers in America that look at whether high consultation rates equals good care, and they found that it didn't. They found that if you saw more than 20 clients a day, the quality of care went down. Unfortunately, this data is in American veterinary journals. But it seems a pity we can't treat people with the same consideration that we treat cats. So what would be clinically safe? 25 consultations a day was considered an absolute limit. And maybe we should try and expand on this a bit. In hospitals in the UK, they're looking at safe staffing levels. We should look at this in general practice as well. What is a safe number of patients for a doctor to see in a day? One question was, how long do you spend in consultation? 15 minutes or less. Croatia spends 4 minutes, apparently, in consultation, but most people felt that they were spending 10, 12, 15 minutes. Some lucky countries spend a lot more, and that's where we should be aiming. When we asked how long it should be, almost everyone thought it ought to be around 20 minutes, and some people thought even more. Sweden felt that for certain cases, it should be up to 45 minutes per patient, especially for those with mental health issues. So what are your working hours? Some countries stick to what is considered a normal working day. That is 8 hours or that sort of figure. But most countries had considerably more than that. And the tale seems to be in the amount of bureaucracy that they have to deal with. The paperwork, the checking of lab results. And they felt that a manageable working day should be around 8 hours, which is normal for the rest of the population. We are not superheroes. We should recognize our own limits. Do we do home visits? Yes. The majority of countries do at least one, sometimes up to 5, 6, 7, 8. And some countries have considerably high numbers. There is some debate as to whether this should be done by GPs or whether they should be done by other health professionals. And there is an argument that we shouldn't necessarily see every patient at home, that some people are better placed or have more time to go and see people at home. That nurses, paramedics, palliative care experts, all could be used to see home visits that at the moment GPs see all the time. And what about paperwork? It's everyone's bugbear. It's not just the people who have low numbers. Even 20% of a working day is a lot to spend on just paperwork. And some people have as much as 50% of their day looking at results. A lot of this is done in the consultation. But even so, it is time that you spend away from the patient. And could this be done by others? A lot of people thought no, that you need a doctor who is clinically qualified in order to assess results. But it may be that there are some ways in which other people could be trained to look at paperwork and assess it, or that IT could be used better in order to flag up abnormal results. Would resilience training help? Would it help to teach our medical students how to survive in what is a toxic work environment? Most people said yes, that it would be beneficial. Some said either it wasn't recognized or it wasn't part of the curriculum. But although it is valuable to teach people resilience, we also ought to think about the safety of working conditions. If this was an industry, we might be shut down. Because certainly in the UK, 400 doctors have committed suicide in the last 5 years. And for female doctors, the risk of suicide is 4 times that of the general population. You don't go into medicine to increase your suicide risk, and we should do something about working conditions. What about our premises? The majority of people thought they were fine for the moment, that they had enough space, they had enough rooms to accommodate all the people who used them. But a number of countries find that they share their rooms. I have to get out of my room early on a Tuesday in order to let a diabetic nurse have the room for the afternoon. And we should have premises with enough space for everyone. Is there enough capacity for the future? Probably not. That with an aging demographic, with the bulk of medical care being seen in primary care, with more and more of this shift of chronic disease management from previously hospital care into general practice, we need bigger, better facilities. Is there occupational health for GPs? There is for other workers, but there isn't always for general practice. Do we have enough breaks or vacations? By and large, people who said they didn't have enough holidays also said they didn't have enough breaks in the day. And the majority of people feel that no, there is not enough time. And we need time to reflect. We need time to think about the patient we've seen and to reflect on our own work in order to operate safely. Is it possible to work part-time? Almost everywhere they said you could, but with adjustments. Some places can't because there is no one to replace them if they work part-time. Sometimes it means negotiating with other doctors so that you can job share. It's only in Portugal where it's not actually allowed. Do you have control of your work? And most people felt yes. And this is a protection against burnout. Because if you feel you have control of your working day, then you have some protection. Are you able to reject consultations? Most people felt they could say for certain things, this is not my field. You would be better seeing someone else. I am not an expert in this particular area. But in rural areas, this is more difficult. In rural areas, GPs have to do everything because there isn't anyone else. Do you have your own GP? Most countries said yes, they did. But there are still people who don't. And we need to encourage those that they need a separate clinical opinion when it comes to their own health. It is not always easy to recognize your own stress. And isolation, a significant problem in rural areas. And I speak as a GP in a rural area, where it is very difficult to get locums to take over when you want to go on holiday, or have a break, or come to UAMO. And the loss of the GP workforce, which is prevalent not just in the UK, but throughout Europe, increases this problem. So what would help? Well, GPs are innovative. They're good at finding solutions. Most wanted less admin, less bureaucracy. They wanted better support from health bodies and from their governments. They wanted better financing of family medicine so that it's given its true importance in every European health system. They thought a registered list would improve continuity of care. And they thought that a clinically safe consultation has an appropriate time slot. It is not rushed. You have time to talk to the patient, to get them undressed, to examine them, to get them dressed again, and for an elderly person, this can be a considerable amount of time, and to talk to them about your plan of treatment. It was agreed by everyone that good training in family medicine and recognition that we are a specialist discipline would raise the status of GPs and might improve retention and encourage recruitment. Some countries mentioned to try and reduce the fear of litigation, that the financial penalties of complaints or legal procedures is a considerable barrier. So what are the solutions? Well, some have been tried. Multidisciplinary teams, trying to get other people within your practice who will look at problems that are not strictly medical, like the relationship problems, the marriage breakups, the truanting child, the damp housing, social problems that other people are maybe better placed to deal with. There's talk of linking to other neighborhood clinics. Maybe GPs can support each other so that they can fill in the gaps that are missing. We need to manage patient expectations. People expect everything to be perfect, and life is not perfect. And with a shortage of GPs, it is more and more difficult to get an appointment when or where you want it. We need to have good communication with our health bodies. We need to tell them, this is the problem you have. This is coming now. We have been telling you for a long time, it's about to happen, now it's happening. And we need to talk to our patients and to the hospitals. And we need better information technology. We need computers to help us, not to hinder us. In the UK, we could do with better coverage and better speed as a start. The other things I've been doing, I've had meetings with the European Medicines Agency. I presented on the safe prescribing of methotrexate, and I took part in the debate about the risks associated with quinolones and fluoroquinolones, and the advice from that has just come out from the EMA. I also had a meeting earlier this week with the European Policy Centre, and I have already sent you the report of that. I would like to emphasize that the commissioners there were in agreement that general practice should be a priority for Europeans, that it should be funded better, and that they should raise its status by acknowledging it as a speciality. Unfortunately, all these commissioners may be about to lose their jobs. Because of the election, we're going to have a whole new set of people in whom we need to make relationships. Talking of communication, Callum mentioned The Princess Bride, and I like that because I think it is good communication. Inigo Montoya says, hello, which is a polite greeting. He says, my name is Inigo Montoya, which is introduce yourself, tell people your name. You killed my father. You're establishing a relationship with the patient. Prepare to die. You're managing patient expectations. Thank you.